Dear all, good morning. Dear Dr. Brilakis, thank you very much for your invitation. And my today's topic is about therapeutic exercise because I think that this is a very important issue regarding rotator cuff rehabilitation and not only rotator cuff, but in general speaking about tendons. So I was trying to come up with something to tell you about today, how I do it, but I'm not going to do that. I'm gonna let you know how I think about the principles. So, if we know about the principles of rehabilitation and about the tendons, then you can have your own protocol. So, I was trying to find something from the research, and I came with a very good study in 2020. It comes from Philadelphia, and it's comparing expert opinion with the care team regarding post-operative rehabilitation protocol following rotator cuff repair. Guess what? Conclusion. Our findings show that although significant discrepancy of opinion exists with profession, greater differences in preferences exist between surgeons and physical therapists regarding rotator cuff rehabilitation. Sorry about that. But it's fact. People think differently, all right? Another case study in 2021, it's about effectiveness of early versus delayed rehabilitation following rotator cuff repair, and it is a systematic review, and it comes from Manchester. And what they found that statistically significant differences in favor of early rehabilitation for shoulder flexion at 6 weeks and 6 months and 1 year, and similar differences for other planes of movement. In terms of repair integrity, early mobilization does not seem to increase the risk of re-tears. And this is very important because sometimes we see patients in our private clinic as soon as they have like 2 or 3 days after surgery. So we need to know what to expect, and we need to educate also doctors that it's not a big issue if you start early. You're not going to damage their work. Another study from SGRA in 2018, it's about post-operative rehabilitation concepts. So the summary states that during rehabilitation after rotator cuff repair, there should be constant communication with the surgical team. That's true. And what do we need to know from the doctor? We need to know the integrity of the repair. We need to know the quality of the tendon. We need to know the quality of the joint, if there is any arthritis, because don't forget that tendons, they don't have any blood supply. They're poorly blood supplied. So mainly everything comes from the musculotendinous junction and from the bone. So if we have bone defects and bone deficiencies, this is a problem. This is a major problem. So awareness of with the surgical team and awareness of complication management, healing potential of the repaired tendon and anatomy of the shoulder complex are critical. During the early stages, reducing pain and inflammation should be prioritized, followed by progressive restoration of range of motion. But when advancing range of motion, progression from passive, active assisted, and active movements allow for gradual introduction of stress to the healing construct. So we need to know when to apply stress. But regarding the previous survey, it's not a big deal if you start early. Even though time frames are not used in progression, it is important not to place excessive stress on the shoulder for up to 12 weeks to allow for proper tendon to bone healing. As exercises are progressed, scapular muscle activation is initiated, followed by isometric and lastly, isotonic rotator cuff exercises. When treating overhead athletes, advanced strengthening in the overhead position is performed, followed by plyometric training. Regarding plyometric, we can divide the plyometric circle into two phases. It is the concentric and the eccentric. So plyometrics is that circle which starts with concentric and then goes to eccentric, or vice versa. So we need also to remember that the tendons act like recoil. So they stretch and then they give you back the energy in order to perform the movement. It is important that patients are educated early in the rehabilitation so that they can manage their expectation to realistic time frames. Physiotherapy is not only treatment. Physiotherapy is also advising, it's also about coaching. So keep that also in mind. In 2016, the American Society of Shoulder and Elbow Therapists made a concession statement on rehabilitation following arthroscopic rotator cuff repair. And they also state that strengthening exercises should be applied approximately at 12-week post-op. This document represents the first concession rehabilitation statement developed by a multidisciplinary society of international rehabilitation professions specifically for the post-operative care of patients from arthroscopic rotator cuff repairs. And the overarching philosophy of rehabilitation is centered on the principle of the gradual application of controlled stresses to the healing rotator cuff repair with consideration of rotator cuff tear size, tissue quality, and patient variables. Facts. Therapeutic exercise is one of the core skills upon which the profession of physiotherapy is based. Although there are many different professionals involved in delivering advice on physical activity, physios are equipped to provide therapeutic exercise programs in light of their own knowledge of the impact of pathological processes of an individual. Physiotherapists prescribe exercise to manage both acute and chronic conditions and to maximize an individual's functional ability. Facts. Physical activity is any bodily movement produced by skeletal muscles that results in an expenditure of energy. Exercise is a physical activity that is planned or structured. It involves repetitive bodily movement done to improve or maintain one or more components of physical fitness: cardiorespiratory endurance, muscle strength, muscular endurance, flexibility, and bodily composition. So what are the principles of therapeutic exercise? It's FIT. And FIT stands for frequency, intensity, type, and time. Because patients come to our office and they said that the doctor, asked, you can do some exercise to me. So we need to know the principles when we start and how we prescribe therapeutic exercise. Because we all know that, okay, you're gonna have like 3 sets of 10 reps, but how much? How much load? And how can you measure that load? Because I can lift a 5 kilo dumbbell. Anyone can lift, right? But it's not the same amount of effort to me and to my mother. So it's totally different how to measure the load and how to measure and how to apply that load. So I'm going to start with for frequency. Frequency regarding older people like middle-aged and on, you can get maximum results with a session like 2 or 3 times per week. It doesn't have to be every day. And why you don't need to have every day? Because tendons need time to compose collagen and change the tendon matrix. In fact, when someone is coming for treatment and asking for your help, what are we trying to achieve? We are trying to not to heal the tendon on the bone. It's not our job. But it's our job to make that tendon, the collagen of the tendon, to be more, to have that stiffness that you acquire in order to produce the movement. So we cannot heal faster someone. Facts. But we can intervene to the collagen of the tendon, and this is mainly our job, I believe. Depending on an individual recovery and response, choose a frequency of 2 or 3 times a week to stimulate each target muscle group. One session a week has been shown to be just as effective as 2 to 3 times a week for some muscle groups. There is little evidence to suggest that training a muscle more than 2 to 3 times a week or that split routines will produce greater gains in muscular strength, hypertrophy, power, or endurance. Just a quick discrimination about strength and power. Strength is the ability to move a resistance. Strength, power, is the ability to move a resistance in a short period of time. So this is a very nice. Do we have a pointer? Okay. So this is a very nice. It's about how tendons react to load. So this is time zero, and from time zero is the day that you give exercise to someone. So how the collagen really reacts? There are two lines: the green line and somehow red line. So you can see that when you give someone an exercise and it is a prescribed therapeutic exercise, in the first 24 hours, the collagen rapidly decreases. On the other hand, we have like that protein synthesis in the first 24 hours. But the overall, thank you. The overall is that the over or the overall is that in the first 24 hours you have a degradation of your matrix. So, τώρα αυτό δείχνει. Ωραία. Επομένως, so we see that in the first 24 hours, the average of protein synthesis and degradation is negative. So we have more collagen degradation rather than protein synthesis. And what happens after 36 hours? We have that balance going to positive, right? So at this point, the overall between protein synthesis and degradation of your collagen is starting to be positive. So what really shows us is that you give an exercise, don't do it the other day. You need time, and the tendon needs time in order to be anabolic and not catabolic all the time. What do we say about intensity? So because I'm going to exercise today. So the 60-year-old male goes for treatment and says, I'm going to do exercise today. Okay, how much? And intensity is defined by load. How much load? We need every time to keep in mind that we need to measure how much load we're going to apply. There is a rule of 10 RMs, and what 10 RM mean? Mean that you can do 10 repetitions with maximum effort, and it is that kind of effort that you cannot do the 11th. If you work that means that your patient is working approximately at 75% of his maximum RPM. There is the rule of 5 on the other side, with these like 5 repetitions, and you work through the spectrum of 86 to 88 of maximum RPM. The rule of 3, it's about 92 and 94% of the maximum. But in the early stages, can we go so aggressively to that tendons? No. So it would be very wise to start in the early stages of 40% of maximum repetition and increase 10% per week. In order to have a very good result, you need to have a full range of motion and complete control of the movement. So that means that you can use metronome in order to for the patient to have an acoustical feeling how fast he goes. So if you go 3 seconds up, it has to be 3 seconds down. I'm not talking about right now about plyometrics that you can go 2 seconds up, 4 seconds down. This is totally different topic. But you need therapeutic exercise needs to have full range of motion and complete control of movement. This is when you get your maximum results. We have the Borg scale. Borg scale is a very known scale which indicates how hard an exercise is for the patient. And this is, we have two scales. We have the 10 scale Borg scale, and we have also the 20. I mainly use the 20. And if you keep your patient around 15, which is hard, that means that it equals like 80% of his maximum effort. What about the type? We have the FIT program. So FIT is frequency, intensity, type, and time. We're going to speak about type. Select a mode of exercise that feels comfortable throughout the range of motion. There is very little evidence to support the superiority of free weights or machines for increasing muscular strength, hypertrophy, power, or endurance. In the early beginnings, we usually use isometrics, and isometric is found that it is very good for pain, but also on the other hand is a very angle-specific exercise. But you can also go like 10 degrees up or down to that specific angle, and then you get also your results there. You can use concentric exercises like bands, weightlifting, BFR, like 40 to 80% of limbo occlusion pressure. I usually go at 40, and this is a very good trick not to target so much your joint, but to target on your muscles and your tendons. Then we go for the eccentric, and then remember the recoil effect of the tendons, which include the concentric and eccentric phase during plyometry. Consider how you place your patients before, because this really affects your loading joint throughout muscle torque and muscle strength. If you give someone like a 2 kilo dumbbell, you have to think how much load you apply in the joint. It's not 2 kilo. It's 2 kilo by the distance from the kilo to the joint. So that's the torque. And always we have to think what you target for. If you target the joint, if you target the muscle, or if you target the joint, the tendon. What about time? Typically it's like 20 to 60 minutes. 60 minutes doing exercise. In some cases it's fine, but it's not very often, because you cannot have a 60-year-old male doing like 60 minutes exercise. But there are some 60-year-old guys that they can, but typically it's something between there. And your intervals, your break between each set has to be from 1 to 3 minutes. And if you are working over 90% of your maximum effort, that means that you need like 2 to 3 minutes interval. If you work like 70 to 80%, you need 1 to 2 minutes. Because sometimes, you see patients that they come and, they have to go, but you have to insist on the break. It's very important for them. It's very important not only for them, it's very important also for the proprioceptors to give the feeling back and the brain to understand. Facts. Expect you to conclude. Yeah, I think it's the last one. Tendons need load to increase their stiffness. And regarding tendons, we say that a muscle is a very strong structure, but how can we measure strongness to a tendon? By its stiffness. Tendons need time. Tendons they have blood supply. Their blood supply is very poor. Mainly, their blood supply comes from musculotendinous junction and bone. And in early stages, strength comes mainly from neuromuscular adaptation rather than muscle growth. Thank you very much for your attention.